So just a brief outline of the session today. So the session will be going on till 11:30. We're not looking to take a break today just because we've got quite a lot to get through and we want to make the most of the time we've got together. So we'll be thinking together a little bit about the context of these webinars and also a little bit about definitions and symptoms of the menopause so that we're all thinking about the same. Okay, so just we'll be outlining the 34 signs and symptoms of menopause and just perhaps talking a little bit more about hot flushes, particularly as they are something that are quite common during the menopause and perimenopause. And then we've got Katie Santos, who is a service manager for Hertfordshire Partnership Trust. And she's very, very kindly joining us to talk about her experience of the menopause and asking for help. So Katie will be joining us in a little while. We'll also be talking about asking for help and how to get support. But we've also been joined by Dr. Karen Morton, who's very, very kindly joined us, who has considerable expertise in the menopause and treating the menopause. And she's a consultant obstetrician and gynecologist and has set up her Dr. Morton's, which is an online GP service that you can access via the internet. And there's details about her website at the end of the presentation. So just very, very briefly, we have 3 other menopause webinars in this series. So the second webinar, which I have an awful feeling that it might be full up, but we will be putting on repeats of these webinars, mainly because they've been so popular. I think we probably could have had 400 people attend today. So we have the second webinar, which is looking at exercise, diet and nutrition in the menopause, and we have a number of experts coming to talk to you about those. The third and fourth webinars aren't out on Eventbrite yet, but they will be in the next couple of weeks, so please look out for those. So the third webinar will be focusing on the psychological impact of the menopause, and then the final one will be exploring issues around loss and change and identity and sexual health, and we're hoping to get someone with expertise to come and talk to us about that. At the end of the webinar today, we'd really, really appreciate your feedback. So I'll be cutting and pasting the link for you to put your feedback right at the end of the presentation. So how is menopause understood? Well, I think actually it's more misunderstood than understood. And without knowledge and training, menopause is usually assumed in quite a negative and derogatory way. And some of the connotations that we probably all experience is being it's to do with the mature or older ladies, that it might be about having several hot flushes a day. And there's a general amount of grumpiness and moodiness, as well as quite negative connotations around being barren or dried up, and the idea that this is the change or coming to the end of something. But I think it is a time for change, and I think we all acknowledge that as anyone going through the menopause or supporting somebody going through the menopause, that this taboo about talking about the menopause needs to stop and it needs to change. And I think there's a really lovely quote, Michelle Obama, which is the changes, the highs and the lows and the hormonal shifts, there is power in that, but we were taught to be ashamed of it and to not even seek to understand it or explore it for our own edification, let alone to help the next generation. So I think it's really exciting to think that we're all part of this shift in culture where we can talk about the menopause and not feel ashamed, and we can understand what we need to do to support and help ourselves and others. Liz, I'll hand it over to you.
Okay, thanks, Amanda. Just before I move ahead with the slides, we have got a lot of people on the call today, perhaps about 200 maybe. You are feel free to put your questions to Karen Morton in our chat, and if you could like the ones that are most popular. If we're short of time, we've got a lot of material to get through. There's a massive amount of information out there, particularly at the moment, but we'll hope that Karen will be able to respond to some of the questions. So if you can like the questions, and we'll perhaps look at getting the ones that are most popular responded to, that would be great. Okay, and as Karen said, as Amanda said, for those of you that have just joined, we won't be having a break, but obviously if you need to nip off for anything, then we understand. Please keep yourselves on mute and your cameras off, so that we don't get too many glitches. That's just a reminder for those of you that have perhaps just joined us. Amanda, would you mind responding? We've had 3 emails from 3 people who said the link isn't working. Can you just resend the link again, please?
Yeah. Oh, I'm not sure if I can actually, because I'm in the I can't get out of the presentation.
Right.
Sorry, I'm late. I couldn't get on the link, but I discovered if you copy and paste the hyperlink into the address, bar of your thing, it works.
Yeah. Okay. I think there's also quite a lot of people trying to join, so there might just be a delay in that. But thank you. Thanks for your help. Okay, so we know that there are 3.5 million women over 50 in the workplace, and we know that 3 out of 4 of these women are likely to experience symptoms of the menopause. So that's a huge amount of people that will be affected in the workplace. Next slide, please. Oh gosh. Okay, just admitting a few more people, then we might be able to see. Okay. So as you can see, menopause affects 51% of the population, and it affects people differently. So it has a different impact depending on race, religion, and perhaps other health inequalities. We know that it's a normal part of the aging process, and it's kind of a normal transition that affects all women. Of course, it does affect those within the trans or intersex, but we might not hear from those. So that's just something else to be aware of. It affects women between the ages of 45 and 55, and the average age of onset is 51 years. 3/4 of women will have mild to moderate symptoms, and 25%, a quarter of those that are affected, will have most severe symptoms. Okay. So it's interesting that we often enter the menopause at the peak of our productive lives. So if you think about people who are coming into senior roles in their 40s or in their early 50s, that's a time in your life where things are perhaps ramping up for you in terms of your career, and actually you're then going through this process of menopause. So 89% of nurses are female, and 48% of those are aged over 45. So we know that there's a lot of interest from the media at the moment, and I think NHSE and I have been, NHS England have certainly been promoting menopause, employers becoming menopause friendly over the last 3 or 4 years. 1% of women will experience symptoms of menopause before the age, will go through early menopause before the age of 40. And of course, we also know that some women will go through menopause very, very quickly because of, for example, medication or chemotherapy or surgery or something like that. So support and understanding from managers is crucial and can make a massive difference to how a woman deals with her menopause within the workplace. Thanks, Amanda. So here we can see there are 344,000 registered nurses, and as I say, 88% are female and 12% are male. So it's a huge amount of people that fall into this age category here. 31% are between the ages of 45 to 55. This is some data that we have taken from some slides that we found on the internet. So the figures from our perspective, I'm hoping that this is kind of up-to-date information. We believe that it is. Okay, so just some definitions here for you of when we're talking about menopause, what we're actually meaning. So as the menopause approaches, the supply of eggs in a woman's ovaries dwindle, and the two sex hormones, estrogen and progesterone, fluctuate and then begin to decline. And that's when you get the cessation of periods of menstruation. So premenopause, that's the years when your menstrual cycle is regular, although of course we know that for perhaps lots of women that isn't always necessarily the case, and we know lots of women do have irregular periods but aren't necessarily perimenopausal. So the perimenopause stage, that can last for several years, and it's on either side of your last menstrual period. So as you're going through perimenopause and you're having lots and lots of symptoms of the menopause, you then come to what will be your last period, but of course you don't actually know that it's your last menstrual period until a period of time later. And once you've had 12 months without a menstrual bleed, then that's classed as your menopause, and then after that you're classed as being menopausal. Okay, thanks. So 34 symptoms we've been able to identify as being part of the menopause, and the ones here at the top, the hot flushes, night sweats, irregular periods, loss of libido and vaginal dryness, these are the most common symptoms that many women will suffer from. And then you can see as it goes down, the ones in yellow beneath that again will be fairly common. The ones in the green common, again less common, and then again the ones down in the blue column, there'll be fewer people experiencing those. And I guess it's different for everybody, as we've already said. I guess there's no way of knowing what you're going to get, what symptoms and sensations you're going to get. And I'm sure that Karen, perhaps there might be more that we don't know about, and you can perhaps fill us in on that as we move further forward. Okay, thanks, Amanda. So just talking about hot flushes, because I think they are so common. I'm smiling. I'm just looking at the things that are coming up in the chat whilst I'm talking. Quite funny. Oops, there we are. So hot flushes, as I say, one of the common features of abrupt menopause actually is that people can end up with hot flushes really quickly, and perhaps with certain medications such as chemotherapy. They can last from 1 to 5 minutes, and they can range over a few over the course of a week, or you might have 10 or more in the day, and at night time as well. And they can just be a fleeting sense of warmth to a feeling of being consumed by a raging fire from the inside out, and any of us that have had these will be able to perhaps identify with that. And then you might get a sudden chill as well afterwards, when you've had that kind of flushing, the sweating, and sometimes feeling confused as well. So imagine the impact of having these whilst you're doing a presentation, or you're with a patient, or you're hosting a meeting. Not very pleasant. I can vouch for that, having had them during presentations and during meetings. So nighttime hot flushes, of course, they will disturb your sleep, and you could end up having to change the bed or having a shower and change your nightwear. And then, of course, your sleep is broken anyway, perhaps due to the hot flushes. But of course, if you then got to get up and change the bed as well, all of that takes time, and then we wonder why we're exhausted the next day. So some women don't like the fact that it makes them visible and then vulnerable to comments from others, and they can find that quite embarrassing. They can be really debilitating and can last for years. So that's hot flushes, not nice at all. Okay, so these are just some quotes that we have found in a book. I think it's got lots of quotes from perhaps some well-known celebrities. I like this one. One of my real problems with the menopause was that I had to think about female stuff. So there's kind of no getting away from it then, is there? So it's as much as the beginning of something as it is the end of something. Some women have felt that the forgetfulness that is the early onset of Alzheimer's, because they're beginning to forget really, really important things. And it's not the menopause, it's your menopause. Somebody else felt it was like they'd lost their nerve, and there's an essential ageism and misogyny around the idea that menopause is uniformly tragic. So other people have said that it's a diversity issue and that the face of menopause is very white and middle class. And of course, incontinence, another one of the symptoms. It's not fun when you're on a trampoline where you're wanting to giggle, and of course we know what can happen there, and people can feel like it's not normal. Okay, Samantha. Oops. Okay, sorry, just distracted by people coming in. Okay.
Yeah, I can let them in now, Liz. I've worked out how to do it.
Thank you. Okay, so this is just a sense of what you can do. So coming here, for example, committing to understanding more about the menopause. Reflecting on things, so whether you have any colleagues or team members, so you might not be here for yourself, but you might be here for your colleague or your team members, and thinking about other people that are going through perimenopause and what kind of support they might need. What about your service users, so people that you are seeing in a different capacity? For example, you might be a physio or an occupational therapist, and actually they might be going through the menopause transition, but you're seeing them for something else. You might want to see what your policy is or your guidelines are within your own organisation. Organisations are kind of getting up to speed. I think it's probably a bit of a slow process, but lots of organisations are wanting to become menopause friendly employers, and are seeking to become accredited with HEMPICT, which is an organisation that, as I say, accredits employers. So there's a series of things that you have to achieve and demonstrate that you are a menopause friendly employer to become accredited. So you might want to consider what the workplace is like and the environment and uniforms, and whether any changes might need to be made there. And again, this one has come up already. We're looking at the support and understanding that you receive. So if you're a manager and you're managing colleagues, you're managing women who might have symptoms of menopause, so your support and understanding. So the support and understanding for you and from you, if you're in a management role, is vital to enabling people to have a better experience of the menopause within the workplace. So we're wanting to raise awareness, and we're kind of wanting to empower you, really, I guess, to take this information away and think about what you can do within your own workplace that will make the place better for everybody that will be impacted by this. So you could tell one colleague what you've kind of learned or what you're taking away from here today, and aim to have a culture where menopause can be talked about more openly. So staff, you might want to direct staff to other specialist support or their GP if they need help. And we know that through looking at information out there, there's lots and lots and lots of resources and organisations, and we've put together a list at the end, so we can share that with you. And you might also want to think about flexible working for yourself or for your colleagues who might need support. Okay. Thanks, Amanda. So again, just thinking about what organisations can do. So understanding the impact, the fact that we have had so many people have wanted to join this session, and as Amanda said at the beginning, we think our session later on in the month is already booked up. We're hoping to be able to run another session because we've had so much interest, but it just goes to show that people are, it's a real hot topic at the moment, and people are really wanting to be able to understand and know, perhaps for themselves, for their colleagues, and for service users. So we're looking at we're wanting to raise awareness and understanding, and in the process, I guess, destigmatise, remove that taboo where people just didn't used to talk about the menopause, whereas now we're wanting to kind of shift that and make it okay for it to be talked about. And of course, policies around developing policies or amending policies might be something that you have some influence over and something that you can contribute towards. Education and providing information and training. Again, I think lots of people are wanting to come on our session so that they can feel that they've had some training, that they understand it better, particularly if they've perhaps got colleagues working with them, or they're responsible for staff and maybe they're not at that point themselves in their lives, that actually having some training around it can be really, really beneficial. It can help you to give a better experience in the workplace. So colleagues in occupational health and and HR could be trained also in the menopause. Support networks, champions and ambassadors. I know that lots and lots of trusts around the area have got are setting up networks and have got champions and ambassadors, and indeed we had some people email us that have said that actually they're the sort of the champion of this within their teams, within their services. We're wanting to promote it widely, and of course it's gone out nationally, so hopefully that's a bonus. We're contributing to getting the message out there. Considering uniforms, if you've got lots of staff wearing uniforms, and the environment, and again the flexible working options, can all things that can be considered by you and within your organisation. Okay, so we're at 10:30. So we've asked Katie, some of you might know Katie, anybody who works within HPF team, you might know Katie. We've asked Katie to share her experiences within going through the menopause and seeking help, and perhaps why she sought help and what her experiences have been. So over to you, Katie. Thank you.
Very much. This isn't anxiety provoking at all. So I'm going to share with you some quite confidential stuff, so I'd appreciate it if that stays within this webinar, but I feel it helps to add to my story, which obviously is going to be different to lots of other people's stories. I think I started menopause about 7 years ago. Difficult to tell because I had a coil fitted at the time, so I wasn't having periods, I wasn't sure what was happening, so it was quite tricky to find out exactly what was going on. The first thing I noticed was that I was really, really anxious and quite down. Now, in the past, I've struggled with anxiety and depression myself, and I'm actually on medication permanently for it. So I wasn't sure, but I knew it felt different to normal kind of anxiety. So I went to see my doctor, who promptly said, well, it's your mental health. We need to increase your antidepressants. And I said, I don't think it is. I think it's hormonal. But yeah, that didn't really wash.
Has anything come in the post for me?
Can we ask you to mute yourselves, please? Thank you.
Okay, so I didn't increase my medication. I thought, well, I know enough techniques to manage this. I'll just go away and manage, and it probably is menopause, but you know, whatever. The hot flushes started. Oh my days, the hot flushes. So this is my friend. I don't know if you can see this. This is a fan. It's difficult to see with my background. This comes everywhere with me. It's the best thing I've ever bought. You can use it anywhere, and if people really annoy you, you can wrap their knuckles. So really, really helpful. So I use this all the time. They started and they were almost unbearable. I constantly had the window open at work. I work with male colleagues in my office, so they were frozen most of the time. I told them to live with it because it was me. And I think that's quite a tricky moment altogether when you're working in an environment where other people are not coping, don't understand this or don't know what they're doing. I had to be really honest and just say, look, I think I'm having hot flushes. I'm an old person. Let me get on with it. So I spent many a meeting opening windows, closing windows, as Liz knows, because she was in those meetings, with everyone saying, oh, for goodness sake, you can't be hot again. But I was. So that kind of continued. What I then found was that I was also struggling, obviously, at night time, and also everything started aching. Everything, I couldn't think straight. I was exhausted the whole time, and I can see all the comments going down the side, and I'm thinking, yep, know all those. So I went back to my doctor, and I had a really long discussion, and I said, look, I really think I'm menopausal. Please, can I try HRT? Please, I'll do anything. So eventually we discussed it, and they said, okay, we'll give you HRT. So I started on HRT, and my life changed for the better for a while. I felt so much better. The brain fog went, the hot flushes decreased, everything felt better. Sadly, what then happened was my blood pressure increased. And once my blood pressure increased, they took me off it. So I was taken off HRT, and everything came back. I was told there wasn't really an alternative to that. I would have to deal with it. I then started getting a lot of vaginal dryness. I got pessaries. I had most things that you could think of. The main support that I could get was on Facebook. There's some very good menopause groups on Facebook. And actually I started learning about the symptoms from there, because I just thought, oh, I have no idea what's going on. Everything hurts, everything aches. I can't think straight, I can't sleep. I did talk to my doctor about the sleep, and eventually they agreed to give me Sopiclone 5 a month, so I could get at least 1 night's sleep a week, which has helped, I have to say. I really wish I could have HRT. I would do anything to have HRT, quite honestly. So that carried on. It was a really difficult situation because I didn't know anyone who'd been through it, apart from my mother, who just said, I got migraine and that was it. No one else I knew was struggling with it or didn't say they were struggling with it. So I felt quite isolated, and I felt like I was going crazy at times. Luckily, I've got a very understanding partner who managed the windows open all night. And eventually everyone got sick of me talking about it at work and kind of accepted that's what was going on. And I found the best thing I could do was just be really open and honest, because otherwise they were wondering what I was doing. You know, Alzheimer's, brain, I forget things, I tell people the same things twice. We've made a joke of it now, and they say to me, you know, it's kicked in again, hasn't it? And I say, yeah, sorry, tell me what I just said, because I have not a clue right now. It's the only way I've been able to deal with it at work. it's still ongoing. I'm 7 years in. I've seen a gynecologist recently who said, there's nothing I can do, you need to go to another clinic. I'm waiting to see more people at another clinic because of gynecological stuff. I'm still struggling. This all sounds so depressing. So let me give you the positives. I don't have to shave under my arms anymore. What a result. That is great. That is the best thing ever. Sadly, my chin is not so great. I seem to be growing a beard. You know, pluses and minuses. Other positives, I've managed to talk to a lot of my female friends about this and say, do you realise how this is? Do you know what's going to happen? These are the things that could happen. I've talked to my daughter who's 25 and said, thank you, Lisa. Chin is I've got so many things for plucking my chin. It's untrue. Wax, all kinds of stuff. My daughter who's 25 nearly, I just said to her, look, I'm going to talk to you about this now because you need to know. Beards are so en vogue. It's been a really weird experience and it's not stopped. Last night I was lying there with my feet out of the bed because they were hot. The rest of me was cold. Then I woke up in the night because I was sweating. Then it was stopping again. And I lay there thinking, this is not fair. Why do we have to go through this? And that's my main thing is, it's not fair. I have asked my daughter if I ever end up in an old people's home and I can't remember what I'm doing, the main thing is sort my beard out. I can cope with anything else, but I don't want to be one of those ladies with a beard. I don't know what that's about. The anxiety and depression are manageable now. I use all the CBT techniques that I know through work, through friends. I have some really good friends. And just be honest with people. I think that's the only thing I can say is be honest, try and get support. Sadly, I don't feel like I've had a great deal of support from the medical profession. And in the last 2 years with COVID, I completely understand why. I just wish there was something out there that I could take that would make it better. And I think there isn't now. I've researched and I can't find anything that will help me. So I'm just going on. But the main thing now for me is dryness in every area. My skin, my face, internally, externally, it's all going on. And I don't like that. It makes me feel useless. So, yeah, I've got a lot of moisturiser. But you do survive, and just tell people it's okay. It's okay. You get irritable, it's fine. Explain to people, don't just sit there and suffer, talk to people. That's my main advice. I don't know if that's any help whatsoever, but that's all I can say at the moment. I hope that's okay.
Thank you, Katie. Thank you. Thanks very much for joining us. Thank you. Okay, so yes, yeah, there's lots and lots of things coming in the chat, isn't there? So have we, where are we at in terms of our slides, Amanda? Do we want to
I think this is probably a good point for Karen to come in, actually. Yeah, so I think
you'd be happy to go now, Katie, Karen?
Yeah, absolutely.
Okay.
No problem at all. I'll try and do my best to share my slides. There will be some repetition on what you showed, Liz. I hope you don't mind.
No, that's fine. That's absolutely fine.
Can I just check that you can see that?
Yes, we can. Yep.
Okay, so today is good morning, everybody. It's great to see so many people here. I work at the Royal Surrey Foundation Trust in Guildford, but I'm passionate about women's health for obvious reasons, and passionate about menopause because I am of an age where I have passed 51. So today is not World Menopause Day. That was yesterday. Actually, I don't like the idea that there's a World Menopause Day. I don't like the word transition either, by the way. I don't want to be transitioning from being a solid to a liquid. I want to just be remaining my best self. And I think that's what everybody should be thinking about, just remaining their best selves, not on a journey to to anywhere, just carrying on, being one's best self. So I am going to repeat a little bit about understanding how the ovaries and the uterus and everything work, because I think people don't understand it well enough. And I know Liz has touched on it, but nonetheless, I'm going to touch a bit more. And I'm going to concentrate really on the myths around hormone replacement therapy, not that hormone replacement therapy is the key to everything. Can you see my cursor or not? Can you see my cursor?
Yes.
Great.
Yes, you
Okay.
can, Karen. Yeah.
I make no apology for this hand-done drawing, which appears in the notes of numerous of my gynecology patients' notes, whether they're a young girl of 16 whose periods haven't started, or somebody of 25 whose periods have stopped. I think people don't really understand how the ovaries and the uterus work. So up here we have a brain, and if you were to point backwards for about 4 centimeters from the bridge of your nose, you would find the master gland, the pituitary gland. And it is the pituitary gland that controls all hormone systems in your body, whether it's your thyroid or your adrenal glands or the testes in men or the ovaries in women. So from puberty, the pituitary gland starts to make the ovaries wake up and produce eggs. Now, when you were literally a centimeter tall from head to toe inside your mother's uterus, and the ovaries were a tiny speck, you put into the ovaries all the eggs you're ever going to have. You never make any new eggs, not like the testes that make sperm relentlessly, millions of them every day from puberty to death. And at the beginning of a menstrual cycle, so from puberty onwards, usually 1 egg, sometimes 2, is chosen to be the one that is brought to maturity. The ovary itself is the size of a big plum, and the egg comes to maturity in this follicle, and the follicle grows and grows and grows and grows with the egg inside it on a little mound of cells. And a mature follicle measures about 3 centimeters diameter. So when it is mature, a trigger comes from the pituitary to say ovulate, and the follicle pops and the egg falls out. And the fallopian tube, obviously there are 2, I've only drawn 1, has moved over towards where the egg is going to be shed, and its little fimbriae waft the...
You've muted yourself, Karen. Are you there?
You don't have any sound.
Okay, there you go. Not sure where that came from.
Yeah.
Can you see my slides again or not?
Yeah, we can. Yep.
At what point did you hear about the fallopian tube? Did you
Cut off at wafting.
Okay, right. Well, the egg is wafted in to the fallopian tube by the fimbriae. And obviously in the scheme of evolution, there'll be millions of sperm going swim, 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 and fertilization would occur there. Now, the next thing that happens on the ovary is very important. So the same spot where the egg came from swells again in the second half of the cycle to make the corpus luteum. And the job of the corpus luteum is to make progesterone. And the job of progesterone is to make the lining of the womb all nice and juicy, ready for the fertilized egg, which has wandered down here, to grip on and be nourished until such time as the placenta takes over. Now, of course, there aren't sperm going swim, 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 because humans control their fertility. And so the corpus luteum realizes that there is no pregnancy. And so within a matter of a couple of hours, it shrivels up and disappears, and the progesterone level falls, and the lining of the womb falls away as a period. And then, of course, the whole thing starts again. So this is really important. The ovaries are driven by the pituitary. The ovaries tell the uterus what to do. And the menopause comes when there are no eggs left. Apart from egg production, the ovaries make several hormones. They make 3 types of estrogen, of which estradiol is by far the most important. They only make progesterone when they've made an egg. and they make a small amount of testosterone. Our adrenal glands make another androgen, another male hormone called dihydroepiandrosterone, and it is the pituitary gland making follicular stimulating hormone and luteinizing hormone that drives the ovaries. Okay, so I know you've touched on the definitions, I'll be succinct. The menopause, correctly, it's a single date in time. Liz was right. It's when you look back, you say, I never had another period. The perimenopause is a length of time during which the estrogen receptors in the body shout loudly, where's my estrogen? Where's my estrogen? And that can be a short length of time or a very long length of time. And then there is the rest of your life without estrogen. And that has material impact on the function of your brain, the quality of your bones and soft tissues, so skin, your blood vessels, and what I call the bits below the waist. Okay, some of you may have been to see the Menopause, the musical. It's funny, at least it's amusing. It's a good night out, go with girlfriends. But like so many bits of humor, it's a satirical humor. And actually when I took my team to see it at G Live in Guildford, there were many women who I know perfectly well, although they were laughing, they were actually in pain. In pain because it's so poignant. We've touched upon the range of symptoms that come, and this word map makes it all look quite fun, really. But truthfully, it is definitely not funny. And people will get these symptoms in various combinations and to varying severities. And that brings me to what I call the Gaussian distribution of life. So everything in life has a peak around a Gaussian distribution. And yes, the average age of the menopause is 51. About 0.1% will have the menopause below 30. And that, of course, is decidedly sad and unhealthy. And that's 0.1. And about 1% will have it below 40. Of course, you wouldn't be in the Guinness Book of Records to have a baby at 60. But for most people, it will occur between 45 and 55. And the same applies to which symptoms you're going to get, the severity of those symptoms, and the duration of those symptoms. And importantly, there are no useful predictors for you as an individual as to which symptoms you're going to get, when it's going to start, how long they're going to last. It doesn't matter if you're the healthiest woman in the world who eats really well, exercises really well. Don't kid yourself that for you, it's all going to be fine because you're so conscious, health conscious, and deal with it all so admirably. There are no useful predictors. And then there are the long-term consequences. This is the bit about the rest of your life without estrogen. I'm sure you're aware as health professionals or working in the health sector that heart attacks in women below the age of 50 are relatively rare. But after menopause, they fairly quickly rise up to the same level as in men. We know we have maximum bone density, but bone mass by the time we're 30. And in fact, we lose bone density after that time. And then there's a dramatic reduction in bone mass, again, in an unpredictable way, unless, of course, you've got a family history, in which case you already have a risk factor for that. Of course, brain function will decline as we get older, and it's quite difficult, in fact, if not impossible, to distinguish the effects of aging compared with estrogen deficiency. And it will usually be a bit of a combination of both. You can't attribute absolutely everything to the menopause. Of course, skin changes, we lose collagen, we lose that elastic molecule as we get older. And then there are vaginal changes where the vagina ceases to look like the fabric seersucker, which some of you older ladies will know what it is. It's a lovely, wavy, stretchy fabric. The right word for it medically is that it's rugose. It's very wavy skin. And after menopause, it gradually, over the years, and it's not an immediate thing, but over the years, it becomes flat like a flat sheet and no longer pink and plump and perky. The bladder definitely deteriorates because it too is estrogen, nourished by estrogen. I'm afraid I would absolutely repudiate the idea that menopause has anything to do with your inability to jump on a trampoline. I'm afraid the trampoline is the acid test for the pelvic floor. And after babies, I think for most women, your trampolining days are over. Okay, so who will help? Well, I hope your employers are helping, and that indeed is why you're here today, which is great. GPs, of course, are overstretched. We all know that. It couldn't be more topical at the moment. There are over 600 practices in the UK that do not have a female GP, which is shocking and surprising. I'm not saying that male GPs can't be sympathetic, but obviously it's more likely that a lady GP is going to have some insight and knowledge. But medicine is a very, very big subject. And I think it's up to women to be well informed themselves so that they can seek advice in the best way possible. It is absolutely a time for planning for the second half of your life. When you get to 45, everybody should be learning a bit about it, thinking a bit about it, and coming to their own conclusions about what is going to be right for them. They don't know exactly how it's going to be because there are no useful predictors. Their medical history will obviously have a significant influence on what they do and what they can choose, but their personal preference will be very important. It's a philosophical decision. I cannot overemphasize how important lifestyle and nutrition are. Being overweight is a really serious risk factor for every aspect of your life. And it will not be attributable to menopausal hormonal changes, usually. Of course, there is a weight redistribution that can go along with menopause, but it won't be causing you specifically to be overweight. Exercise is vital. Support groups, menopause cafes, that sort of thing, are wonderful and really helpful. And it may be that a medical approach will be right for you. So I thought I'd talk about the myths around hormone replacement therapy. I am not suggesting that everybody should be on hormone replacement therapy, but I'm suggesting it will be the right option for some women. So the first myth is that you can't start HRT until your periods have stopped. That clearly is rubbish because hormones will be declining before your periods stop. It will be quite common that you might start to miss periods or your periods may change in their character. Of course, as Katie mentioned, many women will come to menopause with an in-date Mirena coil in their uterus, so they're not having periods anyway, or they may be on a progesterone-only contraceptive pill and they're not having periods. But it is absolutely a myth that you can't start HRT until your periods have stopped. Similarly, you can take it for as long as you like. Of course, you need to weigh up the advantages versus any possible disadvantages, but it is absolutely true you can take it till your dying day if you want to. You're only delaying the inevitable. Well, there is a certain amount of truth in this, in as much as some women imagine that they are going to take HRT and it will carry them past the time when their estrogen receptors would shout. So in other words, if they took it for, oh, I'll take it for 2 years, and then when I stop it, maybe I won't get any hot flushes anymore. For the majority of women, their hot flushes will return. They may be less severe, but they will usually return. So it doesn't carry you past the time when you get them. It's unnatural. Well, this is part of the philosophical viewpoint, isn't it? My philosophy is that it's unnatural to live so long, and that the menopause has got later and later. 200 years ago, we were all dead before the menopause, but it hasn't caught up with the fact that we take antibiotics, whatever it is, for illnesses. If your thyroid gland was to stop working, you would definitely take thyroxine, and if you didn't, you would die. So it's a philosophical point. You can't have HRT if you have migraine. Of course, migraine is a contraindication to the combined pill, but the pill and HRT are like chalk and cheese. The pill contains synthetic, strong estrogen that is designed to suppress your ovaries. The estrogen within hormone replacement therapy is natural estrogen, body identical estrogen. There are many women who get premenstrual migraine and they're longing for menopause to come, so they stop getting their migraine. But equally, there will be women who develop migraine or that spectrum of headache for the very first time after menopause, and HRT can be a solution for it. But having migraine is definitely not a contraindication. I'm sorry to disillusion you on this one. Lack of libido is not due to hormone deficiency. It's a multifactorial thing. This is the mug in which my dear husband brought my my morning cup of tea to my bedside this morning. Now, I apply the George Clooney test to ladies who come and tell me that they feel that their sex drive is low. They may be saying that at any age. They might be in their 20s or their 30s, 40s, 50s. Sex drive is multifactorial. So I apply to them the George Clooney test that is whether, if George Clooney was to walk through the door right now, preferably wearing a dinner jacket and with roses and wine you and dine you, if it would get your drives and juices going, there is actually nothing physically or hormonally the matter with you. That said, of course, if the vagina is painful, why would you want to have sex? So it's very important that you keep the vagina pink and plump and perky. Now, HRT does not cause breast cancer. This next slide I'm going to show you is important, and I want you to concentrate on it because it's complicated, and I want you to walk from the top. Don't be tempted to look at the bottom. This is the data from the Women's Health Concern 2015. And really, do you know, it won't ever get any better. I want you to look at the first line only, where you can see that this is based upon 1,000 women in their 6th decade of life. So between 50 and 59, breast cancer is unfortunately a common disease. Within that 6th decade, 12 women per 1,000 who have never taken any form of hormonal treatments, either the pill or HRT or anything, will get breast cancer. And you can see here, incredibly importantly, that being overweight is the biggest risk factor for getting breast cancer, with an excess of 17 per 1,000. If you watched Davina McCall's last documentary, there's going to be another one shortly, you'll have seen her in a ball pit where a few balls fell from the air to add to the background risk. And you will have seen that there was a tumble of balls when she mentioned being overweight. When we get to menopause, we can't alter whether we had children or how old we were when we had children. We can alter how much we drink. And everybody should be having 3 consecutive alcohol-free days per week. Obviously, that's largely for your liver's health, but it will be for your breast health as well. We can't alter whether we took the pill. So combined HRT has a very small but statistically significant increased risk to breast after 5 years of usage. Smoking, although obviously bad for us, doesn't particularly affect the incidence of breast cancer. If you come to menopause without your uterus, so that you don't need to take progesterone to keep the womb lining healthy, then estrogen alone has no effect, no risk to breast at all. Of course, if we get breast cancer, they may be estrogen responsive, and so sadly we would need to stop our breast cancer, but we wouldn't need to think we'd caused it. We can't alter how many babies we had, but we can exercise well and vigorously, and that is more than protective than the small increased risk after 5 years of taking combined HRT. So which HRT? Well, Katie mentioned that she came to menopause with an in-date Mirena, and the Mirena is so widely used by women both as contraception and treatment as heavy periods that it then moves into a new usage as a facilitator for taking estrogen through the bloodstream. Estrogen can be taken as a tablet or a gel or a patch, and more recently a spray has been introduced, which you literally spray on the inner aspect of your forearm. If you have a uterus, you must protect the womb lining either with synthetic progestogen or natural progesterone. If you decide not to take hormone replacement therapy through the bloodstream, do think about your estrogen into the vagina to keep it, I say it again, pink and plump and perky. Do women need to take testosterone? I couldn't agree with Katie more that most women are most concerned about making sure that their friend or daughter, when they lose the plot, has a good pair of eyebrow tweezers to remove those annoying little bristles. The only thing that gets stronger as we get older is hair follicles in the wrong place, which is why men get those horrible bristles on their eyebrows and women get a few bristles on the chin. Some women think that their degree of oomph or maybe their sex drive is improved with a smidge of testosterone. Fair enough, but don't take too much. So women have a huge amount to offer. And I haven't put on here the enormous workforce within the NHS and translate that into the teaching profession as well, where the statistics are not so far different to the NHS. We're going to be 90 if we're lucky, and we want to be our absolute best selves, not just in the workplace, but of course we normally come to menopausal age at a time when our teenagers are stressing us, our parents are stressing us. We are the pivotal people in the community and within our families, as well as within the workplace. And I just encourage you all not to be what my father would have called putter-uppers. Don't struggle with it for years thinking, I'll get through this, I'll get through this. Get expert help and be your best selves. And that's the end of my slideshow. So I'm going to stop sharing.
Yes, thanks, Karen. There's lots of rounds of applause coming there. That was great, wasn't it? Absolutely brilliant. Really, really helpful information.
Sorry to interrupt. I'm still laughing at the idea that everyone's behind there just checking out their chins. That's really really made me laugh. Mine last night, actually. It was you know, one that just you can't get rid of it, and you just and you get it and you're like, yes,
yeah, it's very satisfying, very satisfying.
Sorry, Liz, to interrupt.
So shall we do will you be up for some Q&As, Karen?
Yeah, I'm happy to answer anything.
Okay, so we've got, I think Amanda might have been putting a few themes together. Are there some particular questions, Amanda, that we could put to Karen?
Yeah, I mean, I think I picked some themes out from all of the discussions. So some of the sort of issues have been around sleep issues, and it sounded like Katie, you know, you were taking Zopiclone sort of 5 times a month. I mean, it doesn't sound ideal at all, but is there any advice around, you know, getting better sleep, particularly with the hot flushes and the night sweats, Karen?
Yes, certainly. Can you hear me? Yes.
Yes,
good.
Yeah.
Well, of course, if your sleep is disturbed, you're going to be tired all the time, and so it's important to sleep well. If hormone replacement therapy is appropriate to you, then it's highly likely to make your sleep 1,000 times better. Natural progesterone taken at night has a specific stimulatory effect to GABA receptors. GABA receptors are very important for sleep. So natural progesterone in itself will specifically enhance sleep. Even if you cannot take hormone replacement therapy, usually that will be because of a previous story of breast cancer, not because of hypertension, I would hasten to add. That's not a contraindication to hormone replacement therapy. There is some new data showing that oxybutynin, which is a medication which has been used for many, many years for an irritable bladder, also has a very, very strongly positive effect compared with placebo for hot flushes. So a small dose of oxybutynin can be used for hot flushes and hot sweats, not completely non-hormonal medicine.
That's great. Thank you. That's really helpful.
We can't see you, Amanda. Your screen's black. I'm not sure what you've done.
Oh, I can see me. That's strange. Let me just.
I can see you.
Oh, there we are. We can see you now. Okay.
Okay. Thank you. So, I mean, there's been a lot of comments about hot flushes. Have you got any sort of additional recommendations for dealing with hot flushes and night sweats?
Yeah, I didn't present a slide on CBT. I could have done. I mean, there's a lot of evidence that CBT can be really, really helpful for hot flushes. Because, of course, a hot flush is something that then is fueled by your response to the hot flush. So if I was presenting in front of 100 people and I started to get a hot flush, so that I was getting a bit of sweat running down my nose and I had to get my tissue out, I could think, oh God, I don't think, oh, this is so embarrassing. I don't think I can do this anymore. This is just really just awful. They can all see it. And you get cortisol coming out of your adrenal glands, and the whole thing would escalate, and you might just say, end of story. Most of the CBT work was done on men receiving LHRH agonists to suppress any estrogen production from their testes and within their fat tissues following prostate cancer. So it really does work. So the hot flush comes and you think to yourself, oh, well, nobody can see this. It will pass. I can cope with this. I'll just move around a little more, and you can stop that fueling process. And it's been very, very well worked out. Moira, can't remember her surname, has written extensively on CBT for menopausal symptoms, and it does work. But there we are. If you want a different solution, then of course there are a whole load of herbal things, but I'm afraid the randomized controlled trials have not really shown any significant benefit. But as my grandmother would have said, there's no point in taking Beecham's pills unless you have faith. So maybe placebo is helpful in itself.
Absolutely, that's really helpful, and hopefully I mean, Katie, myself and Liz are all nodding our heads about the CBT bit. We're CBT therapists, so hopefully Liz and maybe Katie might want to join us for the psychological webinar, and we can think about how CBT and that kind of
really important. Yeah,
really helpful. Thank you. So there was a specific mention about burning mouth syndrome. Sorry, I didn't. Did anybody ask about burning mouth syndrome?
It did pop up, Amanda, you're right.
Yeah, so I was just wondering whoever mentioned that in the chat, which was some time ago.
Christine said it was her.
Okay.
Thanks, Christine.
Yeah.
I think I'll include that in the sort of weird and wonderful range of symptoms that women get, probably men get, and go to the doctor about something else completely different. And people hope, and they may be right, that it's attributable to something. And sometimes people will come with a list that is as long as your arm. And I say to them that it's, having weighed up whether it's safe or not, it's perfectly safe for you to take try a hormone replacement therapy regime. It's an experiment. Life is an experiment. The whole of life is an experiment. Some, all, or none of the things on your list will be resolved by taking hormone replacement therapy. Choose just your top 3. Don't think about all of them. Just choose your top 3. And don't become obsessive about it, but just make a little diary of it. Just your top 3. And on a Sunday night, score each of them out of 5. So you could choose hot flushes, you could choose anxiety, you could choose sleep, you could choose aches and pains, you could choose burning mouth, you could choose whatever you like, and score them out of 5, and then start your HRT, and each week just score them, and by the 3rd month you'll really see what you're getting, and then you can make a judgment as to whether you feel that the treatment has been helpful to you or not. So I'm going to have to put the burning mouth in there.
I mean, that sounds like really good advice, actually. Yeah. So whatever your top 3 are, see if you start HRT, kind of check in with yourself on a weekly basis to see if those things are making a difference. Katie, you've got your hand up. Did you want to ask something specifically?
I think, because I've been seeing in the chat, a lot of people are saying, so if you've got high blood pressure, it's not a contraindication for HRT, which I think is actually believed by a lot of people. So if we've been told that previously, or people like me who've been told that, is it worth going and challenging that again with the doctor, or is it worth just going, oh, do you know what, I'm past that bit now?
So it is a contraindication to the combined oral contraceptive pill. And this is where this confusion. And of course, if you were to read the leaflet that comes with HRT, it's all sort of been directly translated across from the combined pill. They are like chalk and cheese. I know I've said that before. I apologize saying it again. Of course, very often people who have high blood pressure have risk factors for other things. And it may well be that the window of opportunity for the use of HRT in a woman is past, so that the risks outweigh the benefits. I'm going to explain this in detail because it's important. Taking HRT before the arteries are furred up can protect the arteries, does protect the arteries from becoming furred up, from developing atherosclerosis. One of the biggest HRT scares came when the Women's Health Study from the States reported in the late 90s. And the trial was stopped. It was thousands and thousands of women. It was stopped because of a number of acute cardiovascular events. Now, an acute cardiovascular event is a heart attack or a stroke, a serious major event. It was a terrible tragedy that they reported it when they did, because they hadn't sub-analyzed their data. They had lumped all those women together. And it was clear when they analyzed it properly that it was the women who had started HRT late. So they had already developed atheroma of their major arteries. And it is absolutely clear that starting hormone replacement therapy then, that the estrogen can actually tickle up the aroma, lift it, the atheroma, lift the plaque, and precipitate an event. So there is a window of opportunity for starting HRT. And that's why I emphasize, don't battle, and then go and see a doctor aged 55, 56, 57, 58, when actually the risks may outweigh the benefits. Does that make sense?
Yes, really, really helpful advice. Katie's nodding, so that's where you're at, Katie, isn't it?
A bit sad now.
Sorry.
But it's really good to have that clarity, isn't it? That actually, I think going and getting HRT if you're struggling with your symptoms earlier rather than waiting until later is perhaps the advice you're giving us, isn't it, Karen?
It is really window of opportunity. Make a conscious. I'm working with a wonderful academic at the University of Surrey. We're producing a conversational AI-driven app, which will, I want the NHS to send, I want Public Health England to send this app to everybody, every woman on their 45th birthday, so that they can start to engage. It's a conversational chatbot which answers questions, and I'm working hard to develop this, because that is when women should be in the same way as women everybody at 60 is sent their bowel screening. Women should be sent, and think of the benefits to the NHS in terms of the workforce and teaching profession and everybody, if we can get this rolled out.
Yeah, it sounds really good, doesn't it?
It's really interesting, isn't it? Because I was looking at the presentation last night, and my teenage daughters were looking, and they were like, "Mum, do you go through all of that? That's awful." And actually, I think we should be having that conversation with our teenage, with our children, not to scare them in any way, but to know that this is something that is going to happen. And the earlier you know about it, the more control potentially you have about that.
I agree with that, but I'm not quite sure about having it on the school curriculum. I think most 14 and 15-year-olds are pretty embarrassed about their mothers anyway. And the idea that they're then going to be knowing about their dry vaginas, I think, is just about this.
I didn't necessarily talk about dry vaginas, but certainly
I'm not sure it's right on the school curriculum. Just mentioning reproductive health, yes, but not in any detail.
Thank you for that. There's quite a lot of
more. There's some more questions and some more themes that we could.
I'm just looking for themes around blood tests and GPs, and I think that's something actually I'd be quite interested in is knowing what we can ask our GPs for. And it sounds like going to the GP and saying, actually, I do want a blood test, and maybe not taking no for an answer.
Okay. Blood tests are singularly pointless. Okay. If a woman comes to see a doctor at the age of 47 and she's describing a whole load of symptoms, it is not a great mystery. There's no mystery in that. Okay. And hormones come into the bloodstream in pulses. So measuring a blood test will not tell you anything further. Blood tests are important if a woman aged 40 stops her periods. She may have a prolactinoma, she may have some other cause. And so that's different. But from 45 onwards, the NICE guidelines are explicit and correct that doing blood tests is absolutely pointless. Okay.
Thank you.
It's really helpful. Thank you.
Can I just say, is there anything that I've just seen someone else put it up, if you can't have HRT, you're now 57 and you're struggling, is there anything that you can take or do to make the symptoms better?
Well, I didn't say that you can't take HRT. I said that the balance of risk needs to be weighed up. And sometimes what I do, I mean, of course, I'm so sorry, Katie, because of course, people who have hypertension do have a risk factor for whatever. There's no reason why they couldn't take progesterone, natural progesterone, to help their sleep as an alternative to Zopiclone, non-addictive, whatever. That's a perfectly reasonable thing. They could certainly take oxybutynin for hot flushes. They can certainly take estrogen into the vagina to nourish the vagina. There are lots of forms of estrogen. Perhaps I'll make a little plug for one here. It can come as creams or pessaries. Some of the pessaries have a plastic applicator per pessary, and I am very against plastic. So I'm very in favor of a pessary that's fairly recently been launched, which is called Invagis, IMVAGGIS, which looks a bit like a suppository. It looks a bit like a licorice comfort. It's a waxy thing. You push it in with your finger, and then it melts, and so it gives some natural moisture, and it releases its active ingredient, which is the same as all the other preparations, and gets into all the nice nooks and crannies. So that's my favorite pessary. But there's no reason why somebody with hypertension can't be using vaginal estrogen. None whatsoever.
Thank you ever so much. That's really helpful.
Are these, sorry, Katie, are these things that we can get from our GP, these things that you're mentioning, Karen, are these things that women can go to the GP and ask for?
Yes, I mean, it may well, I mean, Invagis is quite new, so it might not have gone onto the CCG's green list yet. But I've just put it forward to my Drugs and Therapeutics Committee meeting and similarly the spray, that won't be on the green list yet, but it will be, it will come. They're good products.
Okay. Somebody was asking about itchy skin, rashes popped up.
The same applies to the burning mouth. Might be, might not be.
Yeah.
Obviously, if it's a bit like somebody saying their joints are aching. Well, of course, as we get older, various forms of arthritis may crop up, and so it's the sort of thing to go and present to it. That is something to be presented to the GP for appropriate investigation. And if all other things have been excluded, then yes, it's possible that these things relate to hormone deficiency, in which case it's an experiment.
Okay. Amanda, do you want to just have a would you like to put our link to our feedback questionnaire? We've only got about 10 minutes left, so I'm just conscious of everybody's time. Do you want to put our feedback on the session link into the chat? Could you do that for us? If we could have some feedback from you, that would be really, really helpful on the session. Are there further, if there are further themes that are coming up?
Yeah, there's a couple of, can you see the feedback form on there to click on? Can you? Let me just,
you put that in our.
There we go. Yeah, there was some questions about late menopause, so about sort of mid-50s. I can't remember, was it Lynn? I think you said something about still having periods.
Lucky old them.
Okay.
Secret of eternal youth.
Okay. So was there anything specific you wanted? So yeah, so Lynn, you said you have is late menopause a problem? I'm 54 and fed up with bloody periods.
Well, have a Mirena fitted and then you'll be ready for the next bit of your life.
Oh, okay. That's handy, isn't it? That's handy to know. Very good stuff. Okay, as I say, we've only got a few minutes left. I'm sure we could, there's so many people on the call, Karen, we could ask you lots and lots of questions for quite a long time. We've had some questions about the recording, and we're going to be adding it to our website. You can see all of the information, the www.hereforyou.info. So we'll be uploading it there. So if you've got colleagues who want to access the recording, or you know people that have been trying to get onto the webinar that couldn't make it, then the recording will be available there. As I say, we would like to have some feedback, and we just want to remind you about our service and what we do. We're a staff support hub, and we are offering things like this, webinars. As Amanda mentioned, we've got 3 further webinars booked. We've had some really good feedback about lots of previous webinars that we've run, and with this kind of a lot of demand for the webinars that we're doing. We're doing lots of in-reach. We can come into your teams. We're doing lots of reflective practice sessions. But if you've got any questions or any queries or anything you think we can help you with as a team or group or groups, then do get in touch with us. Our emails are on our screen. So that's just a quick whiz through rather than pulling up our slides and going through those. Amanda's just popped the link into the chat. So if we could have some feedback about the session today. I think, Karen, thank you so much for joining us and at such short notice. We've got a list of resources. We will upload our slides as well to the webinar, to the website, so that you can see the list of resources. We've put Karen's website on there. There's the British Menopause Society, there's the NHS Employers website and what they're advising about organisations to do about menopause. So we'll share our slides again on our website so that you can access things. Any final questions? Anything pressing, Amanda, that's come up?
I mean, there's some specific questions. So I think it's Fleur. She was recommended to take magnesium citrate, and she asked, "What do you think about that, Karen?"
Not a lot is the answer. I can't imagine why magnesium. I wonder if she really means magnesium citrate. I just can't think why would one take magnesium citrate. Potassium citrate is good for irritable bladders, but I'm an honest woman and I've never heard of magnesium citrate.
Okay, maybe for symptoms.
Yeah, so we've got magnesium for sleeping, magnesium for restless legs.
Okay, interesting. Okay,
yeah, so dietary supplements, I guess. Okay. Kelly had her hand up, I believe. Kelly, do you want to?
Oh, yeah. Yeah, I get vaginal dryness occasionally. I think I'm going through the very start of the perimenopause, but I wanted to know if you could recommend any gels that aren't actually hormone based that you can buy from the chemist.
Yes, I think the best one is the Yes moisturizer, vaginal moisturizer.
Brilliant, thank you.
Okay, anything? Your hand's still up there, Kelly. Want to pop that down?
Sorry.
That's all right, no problem. We'll be talking in our diet and exercise webinar in it's, I think, 3 weeks' time. That is. We'll have a dietitian joining us who'll be perhaps talking about what you can do diet-wise, the things that you need to be eating So we've got Fern Doddleston from HPFT, she's joining us, and we have Lauren from Jump and Juice, and she's going to be talking about how important exercise is, things that we've already mentioned today. We'll be talking about that in our November webinar. And again, we'll be recording that. We'll be putting out the how do we get on the next webinars mentioned. We'll be recording the webinars going forward, and again, we'll be adding them to our website. Okay. Okay, I think we should finish. We should call it a day. We should finish now. Anything else? Anybody? Thank you. I'm hopeful. Hopefully, thank you, Katie, very much for joining us and for sharing with us. Thank you, everybody else, for your contributions and comments. Katie?
Sorry, I just saw someone asking about support groups. If anyone's in HPFT, we've actually got a menopause group to look at this at the moment, which we are trying to develop. And if anyone's interested in a support group of any kind, if you want to contact me, that's absolutely fine. I'll put my email in the chat, and then I'm happy to kind of coordinate something. Okay?
Kelly's saying yes, please. Do come along and join us, Kelly. Okay,
Yeah,
and we will. Thanks, Katie.
Sorry.
Thank you, Karen.
You're very welcome. Goodbye.
Thank you. Bye now. Bye bye.
There was just an additional question about the last two webinars, and the flyers aren't out for those yet. Liz and I have still got to put those together and get the links together for those. So look out in those. Look out in your sort of organisation's communication, and they'll be out fairly soon, hopefully in the next week or so.
Okay, thank you so much, everybody. We'll see you next time.
Thank you. Bye bye.